Good afternoon, everyone. First, I would like to thank for giving me the opportunity to be here to speak about cardiac management. So once we say cardiac management, it is a complex way of treating patient with heart disease. So here heart disease means specifically when there is a block in a blood vessel which is carrying blood to the heart muscle. If it is blocked, how we are going to manage this patient? So we all know when we say heart vessels or blood vessel disease, then immediately what comes to our mind is couple of procedure which is done routinely. One is a bypass surgery, another one is angioplasty and medication. So this is a three-way to treat a patient with heart disease. But today our presentation is to introduce another new way to treat the heart disease, and this treatment is called enhanced external counterpulsation. This is a non-invasive treatment to patient with heart disease so that this patient can be treated effectively without going for a bypass surgery and angioplasty. So when I say effectively as an alternative for bypass and angioplasty, now since it is a academic circle, we need to show evidence. That evidence will make this treatment as an alternative for a treatment for heart disease. Now here, management of coronary artery disease or the blood vessel blockage in the coronary vessel is a complex, as does the treatment is. As I said, there are a lot of ways to treat a patient with heart disease. It could be a bypass surgery or angioplasty or a complex medical management. But that doesn't have to be so tough. It is easier to understand if you can able to see the illustration. It's very simple. What this illustration shows is a horse is pulling a wagon on a steep hill. And this is what the entire cardiovascular disease management lies. For example, if you see, the horse has to pull harder and harder if the steep is steeper and steeper. So if it's going to pull it uphill and it is very steep, then it is difficult for the horse to do it. So that is the heart. For example, you consider the horse as a heart. So if it is going to be difficult for the horse, then it is a patient who will have difficulty in doing routine activity. So what does the steep actually signifies? The steep is what the heart has to push the blood across. So we all know the heart's main function is to push the blood into the entire circulation. So the blood has to go to every part of the organ and every cell in your body. To do so, the heart has to push the blood into the blood vessel. And if you understand, the blood vessel runs thousands or in fact 1 lakh kilometers inside our body. So the blood vessel is what determines how much the heart has to push. Let us assume you have a disease. So the blood vessel is stiffer than normal. So if the blood vessel is stiffer than normal, then the heart has to push harder and harder. So how good your heart is, eventually it will fail. Even if it's a normal heart and if the vessels are stiff, what will happen is the heart will invariably fail sooner or later in spite of it is in the normal. So what would you do if your vessels are stiff? That is where medical management plays a major role. So most of the medicines you are taking actually will dilate the vessel. So whatever medicines, for example, as I said, there are a lot of drugs as well as lots of plants which can able to dilate the vessel. So if you can able to dilate the vessel, you can make your heart to pump very easy. So if it is able to pump easy, even if the blood flow to the heart muscle is low, it would not have any problem. The second important thing you have to look is, if you look at the wagon, there is a weight. So even if you can able to remove the weight, the heart can able to move faster in the steep hills. It means your heart can able to pump better. So this load is called the preload. Preload is a blood within your heart muscle before it contracts. For example, if your preload is high or the load is very high on the wagon, then what will happen is again the heart will struggle. To make sure the wagon is simple without any weight, there is a one simple medication can do the trick, that is called nitrate. You might have heard whenever a patient gets a chest pain, you will take a sorbitrate or sublingual nitrate under the trunk. Immediately the pain vanishes. The reason is that reduces the preload. It has nothing to do with the blood flow to the heart muscle, it only reduces the preload. So a simple drug, if it can effectively reduce the preload, significantly reduce the load on your horse so that the horse can pull better. So now you have seen the steep road, which is the afterload, and then the load in the cart, which is a preload. The third important thing is the heart itself. So if your heart is not strong, then it cannot able to pull. So you have to nourish the heart. That is where the blood flow comes in. So the final thing is, if there is any reduction in blood flow to the heart muscle, the heart may not able to function properly. Similar to the horse cannot pull the cart uphill. So the three way to look at is, one is the afterload, the steep, second is a preload, the load the cart carries, and third is a heart muscle, which is your hearts. So if you look here, now the management become very clear. So you have medical therapy, you have intervention, whether it is a bypass surgery or angioplasty, and finally we have EECP. So bypass surgery and angioplasty will not have any effect on the steep or in the preload, which is a weight the wagon carries. So the preload and the afterload is not affected by a bypass and angioplasty. They are going to operate only the target, which is the organ, which is your heart or your horse. The problem with bypass and angioplasty, if you do a bypass angioplasty, if the patient's heart is struggling to beat because of the high afterload and preload, still you become symptomatic. So you need a treatment which can able to improve the blood flow. At the same time, it should reduce the demand. So this can be done through a new procedure called enhanced external counterpulsation. This is a only treatment which has a dual effect. It means it can increase the flow and also reduce the demand. Now what does bypass surgery does? Now everybody would have heard about bypass surgery. This is a procedure where a graft has to be placed across the blocked artery. So if you see here is a block. So what they do is they put a graft. The graft has actually bypassed the vessel obstruction so that the blood can flow through this bypass graft rather than going through the blood vessel which is already blocked. So this is an effective way of improving the blood flow distal to the block. So when the blood flow to the distal improves, then what will happen is the heart pumping function can improve, the chest pain can vanish. And this graft are actually taken from multiple sites. Sometimes it is taken from your leg, which is called a saphenous graft. Sometimes it can taken from your arm. It's called a radial graft. Sometimes the graft can come from your chest itself, which is called an internal mammary graft. But the problem is your heart has evolved millions of years. There is one problem in putting a graft close to the heart. If you look here, heart is a pump. It's a dynamic pump which is keep on pumping from the day you are born until the day you die. There is one thing is, all the vessel which is close to the heart has been specially evolved. It means they can able to take the stress of increased blood flow without damaging the blood vessel. But when you take a graft from your leg or your arms or somewhere else and you put it close to the heart, what happens? This graft is exposed to the very high pressure because of the heart pumping, and eventually it will close. So every cardiothoracic surgeon and cardiologist knows this graft will eventually close. So it cannot be considered as a lifelong treatment. It could be considered as a palliative treatment which can give a temporary relief. Now if you go here, the other one is a stent. So stent is what has been introduced in 1970s. So once a stent is introduced, the number of surgeries gone down. So stent has almost replaced most of the surgery as it considered as an alternative. But still surgery evolved because in certain conditions, surgery would be considered better than the stent. If you look here the stent, it's a simple procedure. The first stent, it's not a wire mesh, it's a balloon. A balloon is introduced into the vessel where there is a blockage and the balloon dilates. So the vessel blockage are compressed against the vessel wall. It's not removed, but it was compressed. So once it is left, initially that's what they thought. They open up the vessel is going to stay open, but it didn't happen. Next 6 months, almost 60% of the vessel we have opened has already closed and causes severe symptom. So it didn't work out. So what they did is, instead of opening and leave it, they put a wire mesh inside, and this wire mesh is called the stent. So once the stent is placed inside the blood vessel, then what happened? The restenosis, the closure of the vessel, probability decreases. In fact, rather than 60% in 6 months, it came down to 5 to 10% in 6 months to 1 year. That is a significant reduction, but still people within 2-3 years the stent closes and again they are symptomatic. So what they thought is, rather than putting the stent alone, they use something called a drug eluting stent. So they coated the stent with a drug so that the vessel will not close again or it will not restenosis. But there was a major problem we have to encounter. The restenosis rate has come down because the stent is coated with a drug. But the problem is it resulted something is very bad or very drastic, which is called stent thrombosis. It means rather than the stent slowly closing, suddenly it's closed because of the clots which can accumulate in the stent. This stent thrombosis is worse than stent restenosis because it causes an immediate heart attack or a massive heart attack and death. So you have to be very careful when you are inserting a stent. When you are choosing a drug-eluting stent, the patient should be aware there is also a chance it may cause a massive stent thrombosis and myocardial infarction. Now, as I said, both the stent and the bypass surgery will focus only on the heart, not the vessel outside the heart. So here now we're going to introduce something called an enhanced external counterpulsation. It is a non-invasive procedure where it can able to increase the blood flow to the heart muscle. How it is achieved? You see here the patient will lie down on a treatment table. In the lower leg we put 3 calf. One in the lower calf, lower thigh and upper thigh region. These calves are inflated sequentially, so the pressure is given in the lower limb, and when you compress the lower limb, you compress 2 compartments. One is a venous compartment, another one is an arterial compartment. The venous compartment, what it will do is it increases a preload. When it is increases a preload, it increases a cardiac output. So people who have low cardiac output, which is called heart failure, they will improve with EECP because it can able to improve the cardiac output. Now the other compartment is the arterial compartment. When the arterial compartment is compressed, the system knows when to inflate the cuff exactly at the closure of the aortic valve. So what happened? The reverse blood flow will directly go to the coronary vessel because aortic vessel will be closed. So here what happened? The blood flow to the coronary vessel significantly increases 2 to 3 times the normal. When the blood flow to the coronary vessel increases, it open up lot of small vessel around the blocked artery. So it causes something what we call as angiogenesis or arteriogenesis, which we'll come back to later. Now the inflated cuff has to deflate. So when it deflates, what will happen is it significantly reduces your peripheral vascular resistance, which we were talking before with a cart analogy, which is called your steep. So when the cuff deflates, the afterload suddenly reduces so that the heart can able to pump easily into the dilated vessels. So it increases the coronary perfusion pressure, which is a supply, and reduces the demand, which is the steepness of the hill where the horse has to pull the cart. So when both is achieved, the patient will have an everlasting benefit. So this is what we say as an enhanced external counterpulsation. Now this is something we don't see in a routine angiogram. It is very interesting to see this patient had his one vessel. If you see the arrow mark here, this vessel is 100% occluded. So we expect when there is 100% occlusion in a vessel carrying blood to the heart muscle, you might be having a massive heart attack because we assume there won't be any blood flow at all. But look at this diagram. Even though it is 100% occluded, the small vessel angiogenesis form is so high, the patient did not suffer a heart attack, or it may not because the collateral circulation is so high. So this is what happens during EECP, improving the collateral circulation. So when you want to say about collateral circulation, always remember, because your heart doesn't depend only on the 3 main vessels. If I talk about cardiovascular disease and coronary artery disease, the heart is supplied by 3 major vessels. This is what everybody knows. But what they don't know is the heart has a plan B mechanism. Even the main vessels are closed, it can able to increase the blood flow to the heart muscle depending on what we call as a angiogenesis. So angiogenesis means you can see new capillary formation, or there is already a pre-existing vessel which actually dilates after the vessels are occluded. So arteriogenesis and angiogenesis are very important. Your longevity does not depend upon the stent you put or the graft you have put. It always depend upon how much collateral you can able to generate. So that is why collateral generation can happen during aggressive exercise. So if you can able to exercise and then you can do walking without getting chest pain or shortness of breath, you already formed enough collaterals. So you may not require a bypass surgery or angioplasty. Now this is a big claim saying like a bypass surgery and angioplasty can be avoided, but we need to have a evidence, because in clinical medicine, unless you have a strong evidence, you cannot pursue any treatment or any strategy. Now to summarize, EECP can improve the blood flow to the heart muscle, it can open up the collaterals, and also remember, because it increases the blood flow not only to the heart muscle but into the entire vasculature. So if it does, what it does is it improves the growth factors. Since growth factors can improve the endothelial function. So the endothelial function lining is into your entire body. So many times we have seen a lot of medication, new plants, new drugs are introduced into the cardiology field, and these all have the targets in the blood vessel, not the heart. So you cannot focus only on the heart, but if you focus on the vasculature, when all this improvement happens, naturally the patient will benefit, because there will be a significant reduction in the afterload. Here you can see EECP can increase something called circulatory endothelial progenerator cell. It's a very interesting cell. These cells are called repair cells. So whenever there is a damage happen to your vessels, naturally this progenitor cell will increase in your circulation and try to repair that. But during EECP we have found this progenitor cell significantly increases. So this is one of the mechanisms which your body can naturally stimulate so that it can repair by itself. So here I am going to show you a video of how EECP is done. So this is a treatment table. The patient is lying down on the treatment table. As I said, 3 sets of cuffs are applied to the lower limb. You can see the illustration. You can see the blood vessel, the artery and the vein. Now what will happen? The cuffs compresses and sequentially inflate and reverse the blood. So the blood is reversed in the arterial side. What will happen is, when you are lying down, 60% of the blood is in your lower leg. So when it is reversed, the blood started going to the coronary. Because of the aortic valve is closed, it enters entirely into the coronary circulation. So once it's entered to the coronary circulation, what will happen? This illustration will show how it can able to develop the new vessels. Now if you see here, if you see here, these are all normal coronaries. So you don't see any block. So naturally the blood start flowing into the coronaries, and the blood flow will increase proportionate to the exercise you do. If you are doing an aggressive exercise, proportionately the body will increase the flow here. You can see the blood flow is increasing. So it does not have any blood flow reduction. It is a normal heart. So assume if there is a block happens, what will happen? So now you can see there is a stenosis or an obstruction. Once this obstruction happens, the area below this obstruction will not get enough blood supply. So once it is not getting enough blood supply, this is what we call ischemia. If the ischemia is not treated, it can lead to infarction, heart attack. So what happened during EECP? When you had started doing EECP, the blood flow starts going, but unfortunately it is not able to bypass the stenosis. So what it will do is, because the flow is higher, it will open up these collaterals. As I said before, one is angiogenesis, formation of new vessel, and second is this all 3 major vessels are connected through an interlinking passage called collaterals. This is already exist in your body. So when the flow increases, this collateral channel can open, and this increased collateral can able to restore the blood flow to the ischemic area. Once the blood flow is restored to this ischemic area, then naturally the patient will feel better. His chances of getting heart attack can go down. He can able to walk. His chest pain vanishes. So once you achieve that, the requirement for further interventional procedures like bypass and angioplasty can be avoided. So who are all the patients who can go for EECP? So here is the indications. So anybody with heart disease who have chest pain or shortness of breath and the disease is proven by some of the investigation like a ECG or echo can go for this EECP treatment. Second is many patients in India, they undergo a coronary angiogram, and after undergoing a coronary angiogram they will come to know their vessels are too thin for a bypass surgery or angioplasty. So for them this is the only treatment option available to them. And third is a patient who have a blood vessel blockage which is less than 70% but still have chest pain. So the main reason less than 70% having a chest pain is, one is because of the flow, and second because of the entire vessel, your afterload could be high. So these type of patient less than 70%, bypass and angioplasty is not indicated. So these patients can go for EECP. And fifth one is, many patient now because of the complex coronary anatomy, all vessel cannot be grafted or stented. So they may say like there are 3 vessels, only 2 may be able to stent or only 1 we can able to graft. In that condition, the remaining vessels is left alone, unattempted. For these type of patient also, EECP is the only option. Another one is comorbid illness. So many patients will have comorbid illness. Coronary artery disease is not an isolated, it is associated with diabetes, hypertension, obesity. So if the patient has other risk factors like pulmonary vascular or renal failure or stroke, which makes surgery or angioplasty high risk, then these patients can also undergo EECP treatment. And finally, there is another group which is a end stage, is called heart failure. So once your heart is failed or its pumping function has drastically reduced, all other procedures become very high risk. So in this condition, patient with heart failure, EECP would be the best option. So other is secondary. So after bypass and stenting, as I clearly stent, the stent you put or the graft you are going to put, it is not going to be lifelong. It might going to close sooner or later sometime. So once it is closed, repeat procedure for bypass and angioplasty would carry a very high risk. So for this group of patient also, EECP could be a better option. So now, you understand what is bypass surgery, you understand what is angioplasty, and you have some understanding about what is EECP. So you have 3 optional treatment available in front of you: bypass surgery, angioplasty and EECP. If I say bypass surgery and angioplasty can be replaced or alternative procedure can be like a EECP can be given as a main focus, then immediately the question would rise, because this is what every patient asks me on the OP. If I avoid bypass surgery or angioplasty, am I higher risk of having a heart attack or death? Because when you advise to go for a bypass and angioplasty, the immediate thing your surgeon or a cardiologist would advise you is, if you neglect going for this bypass and angioplasty, eventually you get into a heart attack, or it could be so massive you may also die. And this is a one driving factor which is driving a huge industry of multi-billion-dollar. So to know or to challenge this, you might have a strong data. Then only you can able to shake this belief. And second is, as I said, when you say you don't need angioplasty bypass and you can give an alternative as an EECP treatment. Now this is where we are having a lot of tap, because as one of the pioneer in bringing EECP in India, and also we work with the ethical committee in US, the one of the predominant question everything asked is, if at all you're going to replace a protocol, if at all you're going to change something, unless you have a strong evidence, you may not even you try to do that. And also you're going to question something which is being easily understood, easily followed across the globe. Now how would you look into it? So if you are a student or a postgraduate or professor or lecturer, all you have to understand is one thing you should understand before questioning anything: fact versus opinion. So you should understand what is fact and what is opinion. So all the time you've been hearing about bypass can able to save your life, can able to prolong your life, it can prevent a heart, or it all fact or opinion. Now let me explain what is fact. If I make a statement if the statement is provable, it has lot of data to support it, and it is genuine, has been followed across the globe because of lot of data is available on that, and that is called a fact. Let me give you an example. A fact means if I say Taj Mahal is in Agra, that is a fact. Nobody can argue with me because Taj Mahal is there and it is in Agra. But if I say Taj Mahal is the most beautiful building in the world, that is not a fact, it's an opinion. You have to be very clear, because why it is an opinion means someone can say, no, we have a building more beautiful than this in Europe. Or somebody can say in Tanjavur, what the temple we are seeing is much beautiful than Taj Mahal. So remember, that is an opinion. So opinion cannot be proven, because I may still think Taj Mahal is beautiful. You may say different, but it is my belief. My belief can be biased because I'm India, I like Taj Mahal. So if you are looking at opinion, opinions are biased, and it is actually given because of your feeling. It is close to truth or it is far away from fact. So what you may hear in online and internet, usually what you are here is an opinion. I can give opinion on anything, but if I want to talk about fact, I will stick it to my profession. That is what the difference between the fact and opinion. So always remember, you can destroy an opinion by using a fact, but you cannot destroy a fact by using an opinion. But this is what happening across the globe. Let me go into it in detail, which you will understand. And second is, all of you would have heard of lot of things about risk reduction. You may say, oh, this drug will reduce your chance of getting a heart attack 30%. This drug will reduce your heart of getting a headache by 20%. So if it is a 30, 40, 50, these numbers are very good, because science speaks on number. Number would not lie, but the interpretation of number can be biased and it can be a lie. Example, if I say, a simple one, I will use COVID as an example. If I say, if I give you this vaccine, it will reduce your risk of COVID hospitalization by 90%. It means if you take this vaccine, your chances of reducing hospitalized because of COVID is reduced by 90%. I think all of you will be ready to take the drug. Well, it's 90% reduction. But this is what you hear. But the same number, if it put it into the different category, it means 100 people in this hall, if they take the vaccine, then what will happen is one will get admitted. If 100 people in this, no one have taken the vaccine, then 10 will get admitted. So 10 minus 1, this 9 is only actually is a 90%. So it is not like what you think. It is actually, the absolute risk reduction is only 9%. But what you understood is a 90%. Similarly, why the number matter is, let us say now, I have a new drug. I have give it to you, and it is have a chance of reducing a heart attack risk by 50%. I don't think anybody will hesitate. Immediately they said, a simple drug, let me take, because it's going to reduce it by 50%. Now, the 50% is what we call it as a relative risk. Now look at the absolute risk. The new wonder drug reduce heart attack from 2 to 100 to 1 to 100. It means in 100 people, if I don't give a drug, 2 get a heart attack. But if 100 people take this drug, then 1 will get a heart attack. It is actually a 1% reduction. So you all believed is a 50%, is actually a simple 1%. So basically, if you are a science student, if at all there is a number comes of risk reduction, 20%, 30%, you should look at it in how much, in what is the full data. The same way I can say, 1 lakh people have not taken a drug and got 1 stroke. My drug can reduce in 1 lakh people who have taken my drug and only 2 had a stroke. So 2 and 1, this 1% reduction, still it is 50%. So remember this, and then we will go to the real data to show what is really happening. The first one is, until 2007, the question of bypass surgery and angioplasty will reduce your risk of heart attack and make you live longer is an irrefutable argument. It's not a fact, but it was an opinion which has been coming from almost 1970s to 2007. And finally someone took a challenge. This is called a courage trial. This courage trial, what they did is they directly compare bypass surgery and angioplasty with the medical management. So what they did is they took almost 2000 patients and all of them have been advised to go for a bypass or angioplasty at the earliest, because this is what you usually hear from your cardiologist. If you don't do it early, you may risk your life, you may get hospitalized or get a heart attack. So boldly what they did is they split it into two groups, each around 1,000 plus, equally split, and one group will go for a angioplasty as it is indicated, and the other group, which is almost 1,138, they've been maintained on the medical management. They did not go for a stenting, they are managed on medical management, and what they did is they follow it for 5 years. Now, what is an expectation? Because it comes from the insurance companies which pays for your angioplasty and bypass. So they want to know after 5 years, how many of them get a heart attack in the treatment group who went for a stent, and how many of them went for a heart attack in a control group which is only on medical management. The answer is surprising, because what they saw is 19% get into a heart attack or death in 5 years in the angioplasty stenting group, and the medical group only 18.5%. So it is almost similar, statistically no difference. So whether you are going for a stent or you manage on medical management, you did not change your risk of getting into a heart attack, or it does not reduce your survival. And they looked at other conditions, hospitalization, stroke, all of them have clearly shown there is no benefit of angioplasty over optimal medical management. Now, this trial questioned the belief that angioplasty and bypass surgery, once the patient has a block, immediately you have to go for angioplasty and bypass. That is considered as an opinion which is lost for almost 30 years. And when it is questioned by the fact, now it's not possible, because the COURAGE trial has clearly shown it is not. Then what did matter? So you did open the vessel, you did make the blood flow better, then what happened? So basically what it does it, you open the vessel and there is a mental relief that your vessels is open, but there is no cardiac relief. Your risk remains the same. Now why it is so? We can come back on later, because the vessel has been opened but still the risk is there. Now if you go to the second trial, now in the COURAGE trial, when the patients are followed up to 3 years, the patient who undergone angioplasty, they did better on symptoms. They have a better symptom, means the symptom is much less than medical management. But after 3 years, that also vanished. So 5 years, 10 years, 15 years follow-up, both the group were almost same. There is no difference between the stenting group and the medical management group. Now, the question is, everybody's background is that at least it is giving a symptom relief. So I would still suggest to go for a stenting, because it might give you a little bit symptom relief than being on a medical management alone. Now, in 2017, it took 10 years for the next trial, which is called Orbita. Now, they looked at something which nobody have looked at, because it is assumed to be a fact, because we thought definitely stenting will relieve your chest pain, because why would you do a stent if it doesn't even relieve your chest pain? Now, the problem in this assumption is there is no clinical trial clearly shown that stenting will reduce chest pain until 2017. So 2017, they did a trial called Orbita. So what they did is they took almost 200 patients. They are split into two groups. So all of them, they were taken into the cath lab, which is a catheterization where they put a stent. So all of them were said they are going to go for a stent, and all of them were taken to the cath lab. The catheter was inserted into the coronary vessels, and only 50% of them received the actual stent and 50% did not receive any stent. They just pulled out the wire and told the patient, you've been already taken a stent. Followed them for 6 weeks. Now, the important thing the trial was done is to prove that stenting should be definitely superior to medical management. But the trial results were again shocking. The shocking trial result was the placebo group also had the same benefit as the stenting group. So this is what we call as a powerful placebo effect. This is a mind over your heart. So the patient all certainly believed they had undergone a stent. So they almost forgot about their angina and everybody started walking without any discomfort. So this trial actually should have changed the entire concept of why stenting should be done. But at the same time, they're all watching, because the other group of cardiologists who are watching the trial, before the trial should publish and there should be a change in the guideline about stenting and bypass, let us publish a trial which can clearly show bypass and angioplasty is superior to medical management. So what they did is In 2020, there was a big trial. It is a $100 million trial, and when we are in US, this trial was been hotly debated. The trial was published, and it's a shocking trial because it again come up with a result which no one expected. Now what they did is, they thought the previous trial, Courage, they would have taken very less sick patients. These patients are actually okay, but because of some commercial interest, they might have gone for an angioplasty. So let us take a very subgroup of patients and then do the trial. So this trial was done where the people have multi-vessel disease. 2 vessels or at least 3 vessels are blocked, and then they have severe ischemia, severe blood flow reduction, the patient has severe chest pain. So this is again 5,000 patients have taken. Because the Courage has given already some fact, they boldly put almost 2,500 patients in medical management alone. And then another 2,000 patients, as per their cardiologist or cardiothoracic requirement, they can go for a surgery or a stent. So they did the procedure and followed them up to 4 years. And then they want to look at the angina, and I want to look at the heart attack risk, and they want to look at the survivability. Now what they saw is, the trial's success depend upon how you define heart attack. So what they made is, they define heart attack in a proper way, and they start looking at the trial. So what they had is, the patient who have undergone bypass surgery or angioplasty has a higher risk of death and heart attack in first 6 months. So if you see here, the first 6 months, the risk of death is or heart attack is around 10%, where in the medical management for 6 months is only 3%. So if you are going for a bypass surgery or angioplasty, your risk increase almost 2.5-fold than the patient who are on medical management. Now it doesn't end there. They follow the patient for 5 years, and they still find out there is no change in the heart attack risk or death in patients who have undergone the bypass and angioplasty treatment when compared to the medical management. Now the problem now here is very clear. Bypass and angioplasty given to a stable patient will not change your risk of getting a heart attack or survival. Then this has a placebo effect also. So these are all palliative treatment to improve some sort of symptom, but will not change the outcome. So in that case, a new treatment which is non-invasive, which could easily increase the blood flow without putting the patient at risk, should be considered and can be considered as a safe alternative. So to put together, to show bypass and angioplasty will not reduce the risk of heart attack, there are so many trials. It is include MAS2 and then ischemia, Courage and Barry 2D trial. All have shown. Now the question is, still if you go to a cardiologist and after doing an angiogram, still the same thing. If you don't do it within 3 days or 6 months, you will suffer a heart attack and your life, survival may reduce. Now, all I have to tell is, whatever you hear from them, I carefully constructed it. When I say a patient go to the clinic and spoke to the cardiologist, means he is stable. Stable means he has chest pain, he has a lot of uncomfortable feeling, but still he may able to carry out this work. In these type of patient, you can safely defer bypass and angioplasty and go for an alternative treatment without affecting your chance of getting into a heart attack or reducing your survivability. Now finally, I am going to conclude showing you a 2 slide which has been shown millions of times across the globe to every patient across the globe, and this is the way stent works. If you see here, you can see it is a 90% block. Clearly you can see there is a 90% block, and which is shown to the patient, and if it is a 90% block, you need to stent the vessel immediately, otherwise there is a high chance of getting a heart attack. Look here, after the stenting, you can clearly see the stenosis has vanished and the blood is normally flowing. So this is a very good example of the success of stent. You open up the vessel and the flow is going normally. Now, in spite of that, because all the reasoning I did is, it did not reduce the risk of heart attack, it did not even reduce your chest pain. So what would be the reason? The reason is, this is what the entire presentation, if you understand these 2 concepts, I think it is fine, even if you don't follow the presentation. Number 1, When you develop a block in your coronary vessels, these blocks are slowly developing over a period of years, not months, period of years. So when they develop for a period of years, these blocks are called stable because the thing which is surrounding the blocks or fibrous caps are very thick. So it will not break. It will only grow inward and obstruct the lumen and causes angina or symptoms, chest pain. But it will never cause a heart attack because it is never going to break. So when you open this vessel, you will not reduce your risk of heart attack. You can only improve the angina. And again, there is another way to look into it. Then why does a heart attack happen? Heart attack happens on a lesions which grows suddenly and immediately rupture when they reach around 10 to 20% or even 30%. This 30% block we see in a coronary angiogram, we don't even touch it, we don't stent it or graft it. But these are the culprit lesion because they have a thin fibrous cap and they can break and causes a massive heart attack. So what you've been believing all this time, more the stenosis, more the risk of death and more the risk of heart attack is actually wrong. And this is not an opinion, it is a fact. The fact is most of the heart attacks are happen where the vessel which is blocked less than 20 to 30%. So the stenosis doesn't matter. And angina, when this anginal symptom also didn't vanish, as I said in one trial, you open the vessel, now you understand the risk doesn't go down. But why did the angina doesn't go? Because what you see is a three main vessel in coronary angiogram, but what interconnecting these vessels are millions of minor vessels. So by the time this lesion slowly grows, the heart also develop its own collaterals and also form its own angiogenesis, and that is why the fact many patients with severe triple vessel disease still they can able to do all the routine activity. So once they are able to do all the routine activity, doing a bypass and angioplasty will not help. I think EECP would be a better option for them in this case of stable patient with symptom, whether it is a single, double or triple vessel disease. So safely the take home message is very simple. So if you want to say EECP is an alternative for patient with angina who are single, double or triple vessel who are stable, yes, it is a fact. It could be a treatment as an subjective or it can be an alternative for a bypass and angioplasty. Thank you.